inflammatory markers. I have no conflicts of interest to declare. The background to the study was that we know worldwide that there's increasing use of ECLS in increasing the complex patient populations in both the paediatric and the adult patient groups. Infection's a big problem. It's one of the most common complications of ECLS, affecting a significant number of ECLS runs with an increasing risk of infections the longer the ECLS run continues, leading to significant morbidity and mortality. It's extremely difficult to diagnose because often the signs are masked with respiratory rate and temperature, leaving you not very many clinical signs to go by. We know that the gold standard diagnosis with microbiological cultures, they take time to grow. And we have a conflicting clinical treatment in the respect that if patients do have infection, we want to ensure that they get appropriate antibiotics as soon as possible. But clearly for patients who don't have infection, we want to minimise the side effects as well as potential antimicrobial resistance. Often hypotension, particularly in children, is an extremely late sign of sepsis, but sometimes for patients on ECMO can be the only sign. So our clinical question was really to see whether or not biomarkers can capture rapidly and accurately to diagnose infection at an earlier stage and be able to differentiate between infection and non-infective SIRS. We know from the ELSA ID task force that the usual diagnostic tools that we use to diagnose ECMO are limited. And as part of that, the Paediatric Critical Care Research Group performed an international survey looking at asking clinicians who look after patients on ECMO what investigations that they do if they suspected infection in their patients. And as you can see, there's a fairly large variability in the investigations that people chose. Almost everyone chose to do some blood cultures. About 2/3 chose to do a CRP, and about 1/3 of the intensivists chose to do a procalcitonin, as well as a varying degree of other cultures. We found that there was 34 studies looking at ECMO and infection in a literature review, and we only found 3 studies looking to see whether or not biomarkers were able to diagnostically evaluate infections on ECMO. Of those 3 studies, there were only about 20 ECLS runs each, totalling 68 combined, of which 20 were paediatric. And incidentally, the 2 adult studies show that procalcitonin was predictive of infection with a cutoff of 2 and 1.89 micromoles per litre, respectively. So to that end, we looked to do a slightly larger trial, looking to see whether or not biomarkers had a predictive value in predicting infection for patients on ECLS. After obtaining ethics approval, we conducted a single-centre retrospective cohort study in a tertiary paediatric ICU in Brisbane, including all paediatric and neonatal ECLS runs between the 1st of January 2015 and the 31st of December 2016. We looked at mainly 3 patient groups, so patients with microbiologically confirmed infection in either blood, urine or sputum, patients with clinically suspected infection, so where the treating clinician thought that the patient had infection and treated with at least 5 days of antibiotics, and patients with no infection. We analysed the biomarkers using the receiver operating characteristics curve to assess the cut-offs as well as their predictive ability, and the infection markers were obtained within 24 hours of microbiological culture positivity. Our baseline demographics, so we analysed data from 65 ECLS runs in that time in 57 individual patients with a median age of 46 days. About half the population were paediatric and half were neonatal. And we had an ECLS mortality of 16% and an in-hospital mortality of 28% over that 2-year period. We analysed almost 600 ECLS run days, where on the vast majority of those days blood cultures were sent, and we only had about a 3% positive bloodstream infections. The vast majority of our positive cultures came from the respiratory tract, with the most common organisms, as you see there. Interestingly, antibiotics were administered on almost half of those ECLS run days, for about 3/4 of which for confirmed infections and about 1/4 for suspected infection. Here we've got frequency distribution of our infection markers, showing that there's a fairly wide range across all of these infection markers. Incidentally, the highest procalcitonin we had here of 520 was from a patient post-ECPR who had no evidence of infection. More than 75% of the procalcitonin and CRP values were above what would normally be considered a cut-off range that would be suggestive of infection in patients who are not on ECLS. Here I have the ROC curves looking at the predictability of procalcitonin, CRP and white cell count to predict infection. You can see here the blue line, we've got procalcitonin, which is pretty much bang on the reference line, suggesting that it would be no better than a coin toss at diagnosing infection. CRP and white cell count showed a relative distance away from the reference line, suggesting that they may be diagnostic, with CRP being quite specific and not very sensitive, and white cell count being probably less specific but more sensitive. But in addition to that, we also looked at not just the individual biomarkers, but whether or not changes in biomarkers over the 24 to 48 hour period of the culture being positive, whether or not that was more predictive of infection. And we also looked to see whether combinations of the biomarkers were more predictive of infection. And this is what we found. So as you can see here, CRP and white cell count were actually fairly similar in their predictive ability in both the confirmed infection group and the confirmed and suspected infection group. We found that changes in the biomarkers over time, either over 24 or 48 hours, didn't really significantly improve their diagnostic ability to diagnose infection. And because CRP and white cell count were the most predictive individual markers, we decided to combine those and to try and identify the cut-offs which would give us the greatest area under the curve to diagnose infection. And what we found was that a CRP that was greater than 99 combined with an abnormal white cell count that was less than 4 and greater than 15 gave us the greatest area under the curve. So we found that in our group there was quite a number of suspected infections and antibiotics to treat that, and that the combination of a high CRP and an abnormal white cell count performed best to diagnose infection. We found, contrary to the previous studies, that procalcitonin performed extremely poorly, and it seemed to be more suggestive of as a severity of illness marker rather than being able to differentiate between infection and non-infection. The strengths was that it's the largest study to date in this population. We conducted a fairly large number of ECLS days with simultaneous culture and biomarker surveillance, and we included all types of paediatric and neonatal ECLS. Limitations are clearly inherent to the fact that it was a single-centre study with a retrospective nature, and in spite of the fact that it was the largest study in this population to date, it's still a very, very small numbers. Interestingly, the majority of our confirmed infections of ventilator-associated pneumonia are from the respiratory tract, and we wonder how much of that was true infection and how much of that was colonisation, given the very small numbers of bloodstream infections. So in summary, CRP combined with, so an abnormal CRP and an abnormal white cell count combined had the most reasonable diagnostic performance. I think in view of the fact that we have such a significant problem with accurately diagnosing infection, I think we need a larger prospective trial to see whether or not a protocol based on infection markers can improve not just antimicrobial stewardship, but also treatment of infections on ECLS. I think because our current markers are so non-specific, novel markers of infection would be needed to help diagnose patients on ECLS, but not only them, but also patients with general sepsis and septic shock in the intensive care unit. And we intend to perform ongoing analyses to see whether or not confounders such as lactate and other severity of illness markers affect the diagnostic performance. I'd like to acknowledge the help of Associate Professor Schlattbach and the rest of the LCCH ECLS team. Thank you very much.
Thanks, Irene. Two questions. Firstly, if you could just confirm for us how much of what you've presented is your own work as opposed to the contributions of your co-authors. Secondly, regarding your gold standard diagnosis for infection, which seems to have been culture results, did you consider trying to differentiate, particularly for blood or urine specimens, differentiating between colonising and pathogenic organisms, and how might you have done this?
So I did most of the work. I had some help from Professor Schlappach with the statistics. And in response to how it was difficult to differentiate, really, for patients on ECMO, how much of it was colonisation and how much of it was true infection, because we didn't really, I guess they're a fairly vulnerable patient group with very few clinical signs to go by. And so, no, we weren't really able to differentiate whether or not they were colonised or true infection.
So you've suggested that a CRP greater than 99 and a white cell count greater than 15 are the major predictors. Do you know, is there any risk of taking continuous variables like that and using cut-offs, first of all? And then second, how did you come at those thresholds?
So I'm not sure about your first question. I'm not sure, I don't know any risks in terms of using continuous variables that way. In answering your second question, we looked at various different cut-offs along the line to see which combinations would give us the greatest area under the curve.
Maybe I missed it. Your age group was between 0 and 8, just under 18. And 83% of your patients were from VA ECMO. Can I just get an idea what's the age group bracket that's dominated your cohort? Was it 0 to 4, 4 to 8, etc.? Or was it spread out over 0 and 18? Maybe I missed it, maybe it was one of your
Yeah, so I didn't put them specifically that way. There was a median age of about 46 days, so there was about half. So there was 32 which were neonatal runs, and there was 33 runs which were paediatric. So about half the cohort were neonatal.
Irene, thanks. Could the actual presence of the ECMO circuit in the membrane itself have influenced the findings and the measurements that you got? And do you think there'd be any way to measure that?
Yes, I think certainly the ECMO membrane can certainly affect, and I think it certainly did elevate the baseline levels of the biomarkers. You could see that, more than 75% of people had a procalcitonin or CRP that was well above what would normally be considered treatment cut-offs for infection. And I think, looking to see that the changes of those biomarkers over time also didn't seem to predict infection, which would suggest that all of the biomarkers that we have are not very specific at being able to differentiate between non-infection and infection.
Irene, meningitis is a very important septic subdiagnosis in this group. Clearly, you can't do LPs on this group. No. Was meningitis or suspicion of meningitis prevalent within the notes of those that you studied?
It wasn't very prevalent. We suspected meningitis on one of those patients out of the 57 due to patient having seizures on ECMO with high inflammatory markers. Clearly we couldn't do an LP, but it was clinically suspicious and we did treat on that basis.